Welcome to Nasdaq Trade Talks. I'm Jill Malandrino, Global Markets Reporter at Nasdaq. Joining me is Dr. Stephen Soloway to discuss the future of telehealth and its swift growth in March and April this year due to an acceleration in demand with the coronavirus as it permits healthcare services to be delivered without in-person contact, reducing the risk of disease transmission and freeing up in-person healthcare resources for COVID-19 patients. And Dr. Soloway, the question is, as people reemerge to a new normal and go back for medical care more regularly, do you think telehealth will still see the volume of patients it saw during the COVID-19 lockdown?
The telehealth is probably going to be around forever. It's not something that I'm a fan of. I think it distracts from the doctor-patient relationship. I talk about this in my book, and I think in chapter 3, I have a whole thing on telemedicine. And one of the things that, at least as a practicing physician who sees patients, as opposed to a radiologist who looks at pictures. Now there's exception of psychiatry where there's really no physical exam other than observation, and even there is some observation that needs to be done in person. But like in my field, or in any internal medicine field or surgery field, you have to look, feel, I mean, your history is important, but your physical exam is very important, and you cannot do a physical exam only by you cannot do a physical exam only by observation on a TV screen. You know,
Right.
the TV screen gives you a view, of course, you can see. I mean, I can see, you know, your hair color, I can see your eye color, I can see if you're wearing lipstick, I can see if you're making any facial oddities, twitches, smiles, frowns. I can, you know, and there is a lot that a very inquisitive doctor can get out of a visit, especially if he knows the patient very well, or if he's, I don't want to incorrectly state this, but if you're jaded and you're looking for something, you can almost try to find it in that face or in that expression that the person's making. You know, some people, they just have a certain look about them and they may look like they're frowning, but that's just their look. And if it's your first time speaking to them on telemedicine, you may misread them completely, and you may think they're being stoic when they're not, or vice versa. So while I think it's an important tool and it adds to the arsenal of what can be done, I think it's unfair, both to the doctor and the patient, to become too reliant on something like this. I would say akin to going to school on a computer as opposed to having the actual college experience or high school experience. While it's true the data can be transmitted, it can't be interpreted the same. And the same would go for the medical conferences. Personally, you know, everyone has their own way in medicine of getting their continuing education credits. I like to go once a year to Boston to the review course they have up there for 5 days. I'm not reviewing for anything, but I like the review. And I like the fact that there's people there at my level that I can ask questions, and vice versa, they can ask me questions. But if the whole meeting were on Zoom or Skype, that wouldn't be able to happen. You'd simply be in an audience, like leaning back with your feet up and your, you know, tablet or your paper in front of you. And it would become very difficult. And some of us are so old that there really weren't computers in college. So we're so used to writing and having like a template or slide, not slides, but a
Right, you're used to having physical materials in front of you where you can highlight and take notes. And I'm the same way. And of course, we've all learned how to shift our way of thinking in our practice, not even just specific to COVID-19, but just as technology has evolved. So that's my question to you, Dr. Soloway, and you kind of alluded to it. Do you think traditional doctor visits and the traditional way of practicing medicine and telemedicine could potentially serve together in a hybrid role?
I hope not. I hope they don't. I hope that in situations where a psychiatric patient can't get out, or they're a shut-in, or an old person, I hope that it helps them. I hope that people who can't get to the doctor have the ability to use this technology, because in those cases, something is absolutely better than nothing. But in cases of complicated people from 20 to 65 or 70 years old that get around, if you're going to be able to rely on telemedicine, then you really don't need a trained physician. You can have any mid-level provider do the visit, because it's a matter of, hey, do you know, I took my pill and I got nauseous. What do you think I should do? Don't take that pill again. So you don't need a full medical education to do that. You know, a partial education, one of the abridged training courses to get to be like what they call a mid-level provider, where you're not actually a doctor. You know, you're not an MD or something. You're, you know, like a lower level, and anybody could answer those questions. Maybe a non-physician could answer them because, you know, hey, I'm a mom, I'm a dad, I know everything, so therefore I can answer those questions for you. But when it gets down to the nitty-gritty of the nuances, you know, again, in my field, I treat arthritis, I treat pain, I treat trigger fingers. Those trigger fingers have to be injected. I can't inject them on the computer. Um, people come in with changes in skin color. They come in with different textures of their skin. And some of these are life and death conditions. If I see somebody with scleroderma, I can look and I can make some good assumptions, but I must feel, and then I must look through the like the nail fold with a special light to look at the capillaries in live time. So
Yeah.
I consider myself, and I write this in the book, I consider myself a very astute clinician with 30 years experience, and I still could not perform my high level of care on telemedicine. And honestly, I don't believe that if people think they can, then I think they're misleading themselves and the public.
It is interesting though, and this is something that we've actually covered on my show with Trade Talks. And I do think one of the benefits is for sure when you look at mental health issues, for example, or even going to AA meetings, or if you couldn't see your therapist because
No,
you had to practice
I
social distancing.
concur with
It's
you.
interesting. I think there, yeah.
I concur with you. I did
Hmm.
say that psychiatric
Yep.
visits can absolutely occur. Um,
But for what you do
Absolutely.
as a rheumatologist, to provide some context for the audience, as a rheumatologist, in many circumstances, you have to be able to touch and feel and see and provide a level of care that you can't do virtually just because you physically need to be with someone, is what you're
Yeah.
saying.
So essentially, a rheumatologist is a high-level internist and an orthopedic. So
Hmm.
we're bone doctors basically, bone and soft tissue and connective tissue. So we're seeing rheumatoid arthritis, lupus, scleroderma, osteoporosis, polychondritis, all these things that maybe people have heard of, or only if they've had it or something. But
Hmm.
even if somebody comes in with finger pain and something simple, you have to look at it, you have to feel it, you have to check the temperature of it, you have to touch it, you have to feel the squishiness, the bogginess, the texture. Um, so, you know, there's other fields of medicine, gastroenterology or stomach problems.
Hmm.
You know, you have to feel the belly. You can't just rely on ultrasound. You can't just rely on conversation. Again, you know, doctors formulate a differential diagnosis, a list of what the possibilities are based on the symptoms. So if you tell me right now, my hands hurt and they hurt, you know, every morning, and I ask you the proper questions, well, you know, do you wake up with it? Yes or no? Do you go to bed with it? Yes or no? Is it worse with this? I'm going to immediately come up with a list of 10 things in my head. Well, to narrow the list, I have to examine you.
Hmm.
And also, I have to check the rest of your joints. So even if I can see you from the waist up on here, you know, like you might be able to show me something on your foot, but then I'm still going to want to see it, see if any liquid or
Right.
something can be drained out of it. Um,
Yeah, those are
so
all good points.
those are the reasons why I'm not a fan
Hmm.
of it. I think it's great for perhaps a pandemic situation. Although in the pandemic, my office stayed open the whole time except when I got COVID, and then we closed for a month.
Yeah.
I
Well,
also
as you
think it's
said,
great. Psychiatry is a great example where not only can it be used, I think it should be used more. I think we have a shortage of psychiatrists. Again, that's in my book. I talk about the shortage of certain specialties and why. So I think I should refer people to check some of these topics in my book, because
Mhm.
what we're discussing, I elaborate on even further.
Yep, and I would agree with you there in terms of mental health care. Dr. Soloway, it's great to have you with us. Thanks for joining me on Trade Talks.
My pleasure. Thanks for having me.
And thanks for joining me on Trade Talks. I'm Jill Malandrino, Global Markets Reporter at Nasdaq.